Hello, everyone, and welcome to today's webinar sponsored by Northwest ATTC, the Pacific Southwest ATTC, and the Western State Node of the NIDA Clinical Trials Network. I'm Riley Vest, and I will be your host for today. And we are very excited to have Dr. Stephanie Hooker and Dr. Rebecca Rossom from Health Partners Institute here to talk to us today about opioid clinical decision support in primary care, and that is CTN-0095. Just a couple of quick housekeeping things. First, if you have any questions for Dr. Hooker or Dr. Rossom during the presentation, you can put them in the chat during the presentation and we will answer them after the talk. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. We ask you that you please take this survey as it helps us make sure that we continue to bring content that you're interested in. That email will also have a link to download the slides from today and a link to the Northwest ATTC website where you'll be able to find a recording of the webinar later this week. Additionally, when you registered for today's session, you marked the type of CE or CME credits that you are interested in. For CME credits, you'll receive an email with instructions on how to log into the Stanford CME portal, as well as some other instructions. And this slide just has some information about the CME accreditation. If you selected one of the types of CE credits, you'll receive an email shortly after the session with instructions on how to receive those. And all of this information is in the slides, so there's no need to write anything down right now. Those of you who requested a certificate of attendance will receive that automatically via email in about a week. Okay, on to the webinar. Today's speaker, Dr. Stephanie Hooker, is a research investigator at Health Partners Institute with a background in clinical health psychology and public health. Dr. Hooker's research interests are in behavioral and psychosocial influences on health and disease. The long-term goal of her research program is to develop interventions for health behavior change and well-being that can be delivered in healthcare and community settings. Dr. Hooker completed her PhD and MPH degrees at the University of Colorado, Denver. Prior to joining the Institute in 2019, she completed a postdoctoral fellowship in primary care behavioral health at the University of Minnesota Department of Family Medicine and Community Health. Dr. Rebecca Rossom is a psychiatrist and senior investigator at Health Partners Institute and the site PI for the North Star node of the NIDA CTN. Her research tends to focus on pragmatic trials, including clinical decision support systems, to improve cardiovascular risk for people with bipolar and schizophrenia, improve diagnosis of cognitive impairment, or improve recognition and treatment of OUD. Welcome, Dr. Hooker and Dr. Rossom.
Thanks so much, Riley. And thanks everybody for joining us this afternoon or this morning, wherever you happen to be. I'm Rebecca Rossom. I'm going to start by talking about our Opioid Wizard study, as we call it, sort of more generally, and then pass things over to Stephanie, who's going to talk about some of our mixed method results and a supplemental study that we did. I want to start, though, first by acknowledging our team of investigators and others who have made this research possible. It's a large team. This is a CTN trial that is implemented across 3 sites. My co-PI is Gavin Bard at Hennepin Health in Minneapolis. Lots of co-investigators, project managers, web programmers, Epic programmers, data programmers across all of our sites, including Health Partners, where Stephanie and I are, Geisinger in Pennsylvania, and Ascension outstate Minnesota, and appreciate the funding and the partnership from the CTN, as well as the support we've had from our data specialists at EMIS. Next slide, please. So I'm not going to go deep into background. I think we all know why we're here and why this work is needed. But essentially, we have seen these waves come with the opioid overdose crisis, first driven by prescription opioids and then heroin, and more recently, synthetic opioids. And I think we also all recognize there is much more need than is possible to be met from our specialty care colleagues. And so this led us to think about primary care interventions to address opioid use disorder. Next slide, please. Primary care clinicians, however, don't necessarily feel like they've got the skill set or the time to take this on. In other research, they've identified barriers to prescribing medications for opioid use disorder. And some of these could lend themselves to clinical decision support intervention, things like time constraints, lack of confidence, and lack of institutional support. Next slide, please. And so that got us thinking about, is there any solution? One potential solution that is out there is smartphone apps, which may help. But that leads the clinician to toggle back and forth between the EHR and the apps, and the app doesn't have any information about the patient. And so that means that decision tree is not automated. So instead, we were thinking about how do we integrate guidelines into the electronic health record, where data collection and assimilation could be automated, and we could personalize the decision support for specific patient characteristics and histories. But the problem is things can be complicated with opioid use disorder care. So the NIDA CTN commissioned a white paper, of which Gavin Bart was a co-author. And it really is comprehensive, and it's great, but it's complicated. And I think it'd be really challenging for primary care clinicians to kind of navigate this sort of algorithm with a patient in front of them. And so we started thinking about how we could translate this into more operational and embedded clinical decision support. And one of the reasons we felt like we were reasonably well poised to take this on is we had already done a lot of work in clinical decision support. Most of that had centered around diabetes care and then cardiovascular risk reduction. So what you're looking at is sort of an early view. This goes back about 14, 15 years now, where when we started doing work around cardiovascular risk, we would have printouts for clinicians, and I'll show you the patient view in a second, that prioritize modifiable cardiovascular risk factors for any given patient. So it would describe the patient's lifetime cardiovascular risk, 10-year cardiovascular risk, and then within what we used to call the six-pack, within those 6 modifiable risk factors, prioritize those based on basically how much bang for the buck the patient would get in reducing their cardiovascular risk if those were addressed. So at that point, this was sort of a static display, and clinicians got really good at eyeballing this on their way into the door to get a sense of somebody's cardiovascular risk. Next slide. And we had a similar printout for patients. And so again, similar information, but less reliant on health literacy and numeracy. But patients liked having something that sort of was tailored to them and summarized their risk and gave them ideas for how they can improve the cardiovascular health. Next slide. And we learned through studies, so this was a study we did to improve cardiovascular risk in people with serious mental illness. Feedback really helped. So the way the workflow works with this is when the nurse enters the blood pressure, they get a best practice advisory that says click here to print wizard. And so one click, they print a handout for the clinician and a handout for the patient and distribute those. And we can track that. And so you can see, where are we? Maybe July of 2016 is when we started. Now, April of 2016, we did the clinic training, and then we started in September giving provider level print rate reports. So first we gave print rates by clinic, and then we got a little more granular, and within clinic gave clinician level print rate reports. And started doing that monthly with feedback between our project managers and clinic managers to kind of troubleshoot why print rates may have been low for some clinics. Sometimes it was a rooming staff was new. Sometimes they had trouble printing, and we actually had our Epic and web programmers go out there and map printers to computers just so we could enable this functionality. And over time, we've been able to sustain target print rates above 80% for targeted encounters. So we took that white paper and we spent a year basically cutting it up and putting it back together and restructuring them into what ended up being about 60 decision support algorithms. And then we were funded to do a 6-month feasibility usability pilot of 55 primary care clinicians in 2018. So we had 8 waivered physicians back then. Being waivered was a thing. We gave them all the intervention. We randomized everybody else to intervention or control. and shown that we could successfully implement and test the decision support. And I think most usefully, those primary care clinicians gave us really good feedback to improve the tool, things that we hadn't considered. So I'm not showing you an older version of the pilot tool just in the interest of time, but it was sort of one long scrolling tool, and clinicians said, we don't know when we're done. We don't know exactly how to navigate this. And so we started thinking about how we could make the tool more modular and sort of more like TurboTax, so that experienced clinicians could jump to what they wanted, but less experienced clinicians, we would walk them through sort of the usual workflow. We had other clinicians who said, look, I'm just going to be honest. I'm never going to take this on personally in primary care. Give me an easy button so that I can figure out how to get these patients connected with clinicians who are waivered at that time, or to specialty care or somebody else who will take this on. I think it's important, but this is a skill set I'm just not going to learn. And then we had other clinicians who said, you've had me, do this work and this tool. Then I have to go back to my Epic node and recreate everything I did. Can you have some functionality in there that will blow all this into my progress node? And we thought that's a really good idea too. So we incorporated all those suggestions into sort of the next iteration of the decision support. Next slide, please. So that leads us to what we're talking about today, which is a multi-site cluster randomized trial that includes 92 primary care clinics across 3 sites. So we're targeting folks who are 18 to 75, seen in primary care. They have high risk for opioid use disorder or opioid overdose. So that's an Epic machine learning risk equation. It's a hybrid risk models that estimates a patient's risk of going on to develop opioid use disorder or opioid overdose. I will tell you, I have a love-hate relationship with this model, in part because it is hybrid, so it throws everybody out of the model who already has opioid use disorder or overdose. And of course, your folks that are at highest risk of opioid overdose are those that have opioid use disorder. So we've done a lot of programming outside of that to bring those folks back into who we're identifying as being at risk. We also bring in folks who have an existing diagnosis of opioid use disorder or on a medication for opioid use disorder, or who have had a recent overdose. Defining a recent overdose is more complicated than you might think. It's not coded all that well. What we ended up going with is somebody who's had naloxone administration in our emergency departments on a day when we didn't give them an opioid, because a lot of the naloxone use we were seeing in the emergency department or in our hospitals was after, for example, an endoscopy, and we gave them opioids and then we gave them naloxone. So we do use ICD-10 codes for overdose, but most of ours are identified by naloxone administrations. Our primary outcome measures are an OUD diagnosis within 30 days of index visit. So an index visit is the first time a primary care patient comes in and is eligible, hits those inclusion criteria. And so we're looking at, of those patients at high risk, how many went on to have an OUD diagnosis within 30 days, or a naloxone prescription, or a medication order or referral for OUD treatment. And then we're also looking at total days covered by a medication for OUD in the 90 days after index visit. Next slide. Secondary outcomes, there's a bunch of them. We're looking at some of those same measures at 90 days. We're looking at ED visits, hospitalizations, total cost of care, all-cause mortality, fatal and non-fatal opioid overdoses. We're measuring rates of tool use, so how often are they printing those displays, and I'll show you what the updated display looks like in a minute. We're also doing a lot of mixed methods work. So one of the things we're doing is measuring clinician confidence in treating opioid use disorder prior to go live, and then again at 9 months using surveys. And clinician ratings of satisfaction and acceptability of the tool. And then Stephanie's going to talk a bit about some of the findings we've had with our mixed methods aim, where we're using quantitative and qualitative methods, so surveys and interviews with patients, with clinicians, with leaders, to identify, describe, and quantify barriers and facilitators to implementation, with the ultimate goal of further adapting it to maximize its use and effectiveness. So this is what the updated clinician handout looks like. So this is what it looks like on the screen. And then when the rooming staff click print on that top right-hand button, it'll print both this display and the patient display. So the printouts look identical to this, but for most of our clinics, you just lose the pretty color. Most of our clinics have black and white printing. But ultimately, what we're doing now is prioritizing clinical conditions across multiple conditions. So we can't just rely on, the ACC/AHA estimates of risk, cardiovascular risk. We also have to sort of figure out how do you prioritize risk for things like opioid use disorder. We're doing cognitive impairment, depression, things like that across the spectrum. And so we've got algorithms behind this deciding what's going to be rated that first priority, second, third, and so forth. So for this particular patient, opioid screening is their most pressing clinical concern. It's showing up for this patient because they've had previous heroin use identified, they've had a screen for opioid use disorder and met criteria for severe OUD in the past, but it's not on the problem list, and they don't have an active prescription for naloxone or a mood, and they're also on a benzo. And then you can see other clinical conditions here as well. We call this our clinician handout. I will tell you a lot of clinicians share this with patients, especially if they have higher literacy, because it does give sort of a more granular view of these conditions than the patient handout, which we'll show you next. So the patient handout, again, designed for lower literacy and numeracy, and we use symbols to relay risk and what would be of most benefit to the patient if they took clinical actions. I will also say Stephanie and I spent a lot of time debating how we were going to present this to patients. We know that some of what we find in the EHR either might not be accurate or patients don't agree with. And so we wanted to present this in a way that patients would feel comfortable talking about opioids and their risk for opioid use disorder without alienating them. And Stephanie will present some data that talks about whether patients feel like we hit that mark or not. But here you can see we don't say, hey, we think you've got opioid use disorder. We're saying if you're concerned about opioid use, treatments are available to help you and keep you and your friends and family safe from overdose, and talk with your clinician. Ultimately, we decided the most important message is to give patients is that this is an okay place to seek care for opioid use disorder or talk about your concerns with opioids. Next slide, please. So beyond that printout, there is functionality within Epic itself. So this, when the view we just showed you is sort of that clinical priorities tab in the black box there on the left. But if they click into the meat of what we call Opioid Wizard tool, this is what they see in Epic. And there's a lot going on here, even though we worked really hard to make this as simplified as possible. So the red flag there, we're telling clinicians why somebody is qualifying for this displaying for them. This person has high opioid use disorder risk. Relevant conditions, this patient also may have comorbid depression. The left-hand side there, quick actions then, those are the easy buttons that clinicians were asking us for. With one click, they can order a rescue kit or refer to somebody to prescribe Suboxone within our health system. We know who's got an interest in prescribing Suboxone among our primary care clinicians, or we can get somebody over to specialty care. Anything you see there that looks like a clickable box, it does an action. For a lot of these, then it'll, for example, populate an order for naloxone rescue kit into Epic, just like any other order that clinicians would order. And it kind of sits in that Epic in basket for clinicians to review, edit, delete, or sign, just like any other order. Then that middle box, you see the view PDMP, that portals clinicians directly into the PDMP for Minnesota or Wisconsin for us, and Essentia, and Pennsylvania for Geisinger. And we can use sort of hidden clinician credentials in Epic to automatically log them into the PDMP. So that removes one of those barriers for them not remembering what their username or password is to be able to view the PDMP. And then on the right there, we also provide recent UTOC screening results. This patient hasn't had any. The very top right-hand button there, you'll see something called suggestions. And when we do training with clinicians on this, we really encourage them to use that. What that does is that generates an email to me and my team so that we know which patient, which encounter their question is about. And then they'll let us know if something doesn't look right or they have a question or why, why X or Y. It really helps us troubleshoot the tool and make this better. And then the FAQ sort of answers common questions about what this is and how this works. So the bottom half of the screen then is sort of the meat of the tool itself. Across the top there, you'll see diagnose, select med, Suboxone, and other care. So that sort of is ordered in sort of a logical clinical order of how clinicians would use this. We use the opioid and heroin questions from the TAPs as our screening questions. If either of those are positive, it populates to 6 total questions. And then if that's positive, we bring them to the DSM for full screening. The last thing I'll mention, I told you there was a lot going on this slide. The last thing I'll mention is that round box on the right-hand side. That's the note builder tool. So once the clinician is done with whatever they're going to do in Opioid Wizard, they click that, it generates text on a clipboard, captures every click, everything that they've documented in this tool that they can then cut and paste into their Epic note. All right, next slide, please. So this is just showing you, then we've got the DSM criteria there populated. Once somebody completes the DSM, it tells clinicians if their patient meets criteria for opioid use disorder, and if so, what severity of OUD this person is thought to have. Next slide. All right, and then let's say you're considering starting a medication for opioid use disorder. I think clinicians can feel a little daunted by this, and we've tried to make this as easy as possible. First, the left top-hand side there, we've got an overview, a one-page overview that sort of helps patients understand the difference between methadone, naltrexone, IM naltrexone, and Suboxone, because I think patients at least new to opioid use disorder may not have an idea about, at least in our health system and the health systems in our study, you can't get methadone in our health systems, and you can only get IM naltrexone in specialty care clinic. If you want to stay in your primary care clinic, that really leads you to trying Suboxone. And we ask whether the patient's ready for treatment, and I'll show you in a sec what decision support looks like if they're not, because some patients aren't going to be, and maybe they need to take some things home and think about it. We've got education materials there on the right-hand side, that overview again, some pretty detailed information on medications for OUD, and then a handout for safer use of IV drugs that we'll show you a little bit later. And then the bottom half of this, we are really trying to help clinicians understand for whom these different medications would be indicated. So this is sort of the default view. This patient has no relative contraindications to any of these medications. The radial buttons on the left are pre-populated from things that we can harvest from the EHR, but clinicians can override that if they have more updated information than we've got from what's documented in Epic. This is a male patient, but I will tell you for our female patients, the first thing we're considering is this person pregnant? Because we want to get those patients connected with our high-risk perinatologists. But clinicians may know the patient's pregnant before anything's documented in the EHR. And I think if you go to the next slide, we'll show you kind of what the decision support looks like when there are relative contraindications. Not yet. Okay, so this is somebody not ready for treatment. We're going to recommend they prescribe a rescue kit if somebody's willing to take that home, and ask them to return to clinic soon to assess readiness for treatment. And then they can document what they've done there and exit. All right, now I think, there we go. So this is somebody who has liver disease. And so you can see, ideally, in our health system and others, we would like those folks to be treated in specialty care or a methadone clinic, or, consider IM naltrexone, although that's, used at much lower doses for somebody with liver disease without getting too into the weeds. We do know, however, some patients aren't going to go to specialty care, and some clinicians are still going to treat them in primary care. So even though things are sort of grayed out, we we still make the decision support available to help those clinicians should they choose to prescribe Suboxone in primary care. All right, next slide, please. So then there's, if somebody decides to start Suboxone, I think this is another point where clinicians can feel like this is getting a bit complicated. It is a little bit more complicated to prescribe Suboxone, especially induction compared to some other meds. We have decision support for both at-home and in-clinic induction. We've got 3 starting doses of Suboxone with really detailed instructions for patients that will show you that really is meant to kind of walk them through how to do this. Also a rescue kit. You'll see a rescue kit in lots of places in this decision support. Baseline liver function test, PRN, clonidine, and Zofran, and then a referral for additional substance use disorder resources. We ideally are getting these patients also connected with behavioral health and therapy. We have a SOWS there for patients who want something to take home to kind of measure their opioid withdrawal before they start their Suboxone, because they do need to be in active withdrawal before they start it, or they will precipitate an even worse withdrawal. So all of this is meant to support clinicians who are starting Suboxone for their patients. Next slide. And this is an example of a handout we have for patients. So really walking them through this person starting at 4 milligrams a day. Don't start it until you're in withdrawal. This is what withdrawal looks like. You've got to have at least 3 of these. And then really getting down to specifics. How do you take it? Well, it's either half of an 8 milligram tab or film, 2 milligram tabs, 1 4 milligram. Don't swallow it. Put it under your tongue. Like, we're really trying to be pretty prescriptive, I guess, for lack of a better word, and ideally minimize a lot of back and forth between the patient and the clinician so they can understand what they're supposed to do. And then they wait 1 to 3 hours. And if they feel lousy, they're going to need to take another dose. And if they don't, then they hang out. And then we assess it again. They should assess it again in 6 to 12 hours. And we have this sort of worksheet for patients starting at all 3 of those doses. Next slide, please. And then when patients come back for Suboxone maintenance, what are the things clinicians should be checking in with their patients about? How do they assess whether somebody's on the right dose or maybe needs a lower dose or a higher dose? We sort of walk them through that as well, depending on the answers to those questions. And we can't harvest those from the EHR. Clinicians have to ask them. Next slide. And then the last module here is other care. And we know that clinicians are likely not going to get to this in the first visit, the second visit, maybe the third visit, but there's a lot of comorbidity in folks who have opioid use disorder. So we're assessing whether they use IV drugs. We've got a handout about safer IV drug use. We summarize related information there on the left, provide some decision support around infectious disease care, screenings, and vaccinations. And then also mental health and other substance use care. So they can screen for other substance use disorders using the rest of the TAPs, or we bring them to the embedded smart forms in Epic for assessing depression using the PHQ-9 or anxiety using the GAD-7, or have a link there for a consult to behavioral health. Next slide, please. And this is just an example of sort of the things that we're including in the safety when using IV drug handout. Knowing that some people are going to continue, a lot of people, using IV drugs, how can we help with harm reduction? And so that's really what that handout is focused on. And I think this is where I turn it over to you, Stephanie.
Yeah, it is. All right. So Rebecca's already given a very good overview of our study and the tool. And so my role is to share some results with you. And our mixed methods aim was what we called AIM 5, but it was a very large AIM 5, where we did a series of qualitative interviews with patients and clinicians, as well as surveys with patients and clinicians. So I'm going to share some of the findings that we have ready. So our first task was what we called the design phase. And then we were in this phase trying to understand how clinicians might want to use a tool like this, how we could better design the tool for their needs. And then we also talked to patients. So I'll first talk about what we heard from clinicians. So we interviewed 8 clinicians during our design phase, and these were actually all clinicians who had participated in our pilot study that Rebecca had described. And so they had some familiarity with what we were trying to do, and they could kind of give us feedback on how to do this better. And so our themes are listed here, and the paper is published in the Journal of American Board of Family Medicine if you're interested in kind of a more detailed description of what we found. But ultimately, our clinicians thought primary care was the right place to address opioid use disorder. So, putting an intervention like this in primary care, sometimes we are concerned that primary care clinicians are going to say, this is not something that I think primary care should do, or this should go to specialty care. But we heard pretty clearly that the clinicians thought that primary care was the right place to talk about OUD. A very prominent theme that came out was that clinicians were very concerned about how these discussions would affect their relationships, and the relationships in turn affect their discussions with patients. So clinicians are very open to talking about opioids with patients with whom they have very good, strong relationships. But when that relationship is at all tenuous or it's not very strong, clinicians are a little hesitant to bring up opioid use disorder with those patients. So it was very clear that there would be situations where clinicians wouldn't want to talk about opioid use disorder with certain patients. And so that was a potential barrier for future treatment. Although with patients they felt very comfortable, it was clear that they were willing to talk about OUD with those patients. I think the third bullet is something we hear all the time, is that primary care has a lot of competing priorities, and they have short visits, often only 15 minutes. And these are complex patients that are coming in that have high risk for OUD or have opioid use disorder. And often this was not the primary reason for the visit. So we would be identifying patients who would be high risk, and that patient wouldn't necessarily be coming in to start OUD treatment. So that was a potential issue that would need to be addressed. We also felt that the CDS, we heard that the CDS could be very useful for clinicians, but different clinicians would have different needs in different situations. For example, at the time, a waivered clinician would be the only one who would be prescribing Suboxone. So a lot of the detailed clinical decision support about Suboxone prescriptions were not useful for non-waivered clinicians. And obviously, like some of those waivered clinicians wouldn't need that level of support because they have that experience. But a lot of the clinicians who would be using it would not be waivered at the time, so they wouldn't be able to use that, but they would want to know how to identify a patient quickly who would be a good candidate for treatment. And finally, they felt like there needed to be a lot of organizational support and systems in place to support this type of clinical decision support so that they could use this and feel that they have that backing. In particular, clinicians mentioned not knowing where to send patients who might need additional treatment, right? So that's why we have those kind of easy buttons for referrals to other physicians in primary care or to specialty care, but also adjunctive behavioral treatment. A lot of clinicians were unsure about what the resources were available in the community where they could send their patients. So making sure that all of those supportive situations were in place for them to be able to use this optimally. So after we had gotten into the field and we had the opioid use disorder tool in place in primary care, we interviewed clinicians and leaders to kind of hear about how it was going and to understand how they were using the tool, whether or not they felt it was useful. And so these were all clinicians who didn't volunteer for a pilot on opioid use disorder. These were clinicians in practice who we had reached out to. So we heard very similar themes from these clinicians, but there were some more themes that didn't come out as much in the pilot. And a very clear theme is that there's clinicians actually prefer to not talk about opioid use risk or treatment with patients. They felt that, again, sometimes these patients were complex. We heard a lot of stigmatizing beliefs about patients with OUD, such as they're they're difficult, they're hard to treat, and this is a topic that's not going to help my relationship. Again, relationships coming out as very important to primary care clinicians. They raved about our CDS tool that was cardiovascular disease focused. They really liked that part of the CDS, and as Rebecca had mentioned, we had very high use rates and had been in practice for a number of years before we started working on opioid use disorder. But they didn't express that same level of enthusiasm when talking about opioid use disorder. And so it was a very clear contrast in terms of a CDS for one condition where they felt like this was in their wheelhouse and something that they could easily address, compared to opioid use disorder, which was kind of on the periphery of what they were really concerned about treating with their patients. We heard about a lot of contextual barriers in primary care that limited their use of the tool. In particular, COVID happened when we had implemented this tool. So we heard about staff turnover, and which led to not having people trained on what they're supposed to do with the CDS. And a lot of those barriers became things that address their ability to use the tool. However, we did hear that, a CDS can be valuable, especially a CDS for OUD can be valuable if it's simple, it's visible, so it's easy for them to find. If it saves them time, it can't add time, it can't be a kind of a wash of time. Like, clinicians are looking for something that's going to save them time, and ultimately has to add value to care. So they have to feel that it would be useful for them and their patients. And they did see that the CDS was valuable in identifying and screening patients and facilitating referrals. And again, these were for mostly patients or clinicians who were not waivered. And the idea that they didn't want to dig in too much into OUD, right? Like, I want to be able to identify somebody who has OUD. I want to know that they are ready for treatment. And if so, I'm going to refer them because I'm not going to be the one that's going to treat that. So, this paper is in press in the Journal of the American Board of Family Medicine. It'll be out probably later this year for those who are interested more in the details of these findings. So kind of going back a little bit to our design phase, kind of our complement to our talking to clinicians about OUD care and the tool, we talked to our patients who would be targeted as potentially eligible for this tool. So during the design phase, we really wanted to understand what are patients' perceptions of these discussions about opioid risk in primary care, and what do they want us to do when we're thinking about what language to use, how to present these messages. As Rebecca mentioned, we spent a lot of time thinking about how to convey risk to people who might not believe that they have high risk or might not have high risk, where we think they have high risk, and trying to make sure it would leave people open for those conversations. And so we found that we had different buckets of patients that we interviewed, and kind of reflecting our inclusion criteria for the tool, we had patients who we identified as high risk, but didn't have diagnoses of opioid use disorder. And some of those people might have just been getting acute prescriptions for opioids because they had a series of surgeries in a short amount of time, or they were on chronic opioids for chronic pain. So they were kind of getting monthly prescriptions for opioids, but they didn't perceive that they had a problem with opioids, or didn't see that they had an opioid use disorder. And another bucket of patients we found were people who had an active opioid use disorder, some of whom were open to treatment and were in treatment. And then there were others that were aware that they had OUD but didn't want to be involved in treatment. So, with these different buckets of patients that clinicians could possibly be talking to, we realized that clinicians would have to tailor the way they talk to these patients about OUD risk and what their treatment options are in order to maximize the likelihood that people would be open to treatment. And so we found, and kind of going along with these themes, we found that, patients kind of develop a sense of a clinician's willingness to prescribe opioids, like and I'm thinking like medications for pain, because they realize that some clinicians are very open to this, whereas others kind of are not open at all. And then depending on the patient's desire to get opioids, they might go to certain clinicians or others. Similarly, they see this kind of their sense of their willingness to treat opioid use disorder and willingness to talk about that varied among clinicians. So patients were kind of becoming aware of that clinicians' willingness to work with them on this problem. Patients were generally open to talking about opioid risk, but had really diverse preferences for how, with whom, and what terminology they wanted to use. So patients who were had active opioid use disorder were very comfortable with terms like addiction and dependence and things like that. Whereas patients who were not a person who identified as somebody who had opioid use disorder, they felt like they did not like that term addiction. They felt it was stigmatizing, that they didn't want to be called an addict. And so there was kind of this different level of comfort with different terms. And we've always been talking about how opioid use disorder is a very clinical term. It's not something that's out there in the community as much. So the term addiction, it seems to be the one that's being used, most frequently. However, patients vary in their level of comfort with that term. Patients felt like primary care is the right place to talk about opioid risk. Most patients felt like they had a very good relationship with their primary care doctor and that they were willing to talk about this with them. We did hear from a couple of people who said they would not want to talk to their primary care about this because that, either that would change their relationship or they felt like that primary care doctor did not have the expertise to talk about substance use problems. Patients generally had limited awareness of overdose rescue medications, especially among patients who were not somebody that we identified as somebody with opioid use disorder. So people like with chronic opioid prescriptions were generally unaware that there was medications out there for preventing overdose or reversing overdose. And finally, we, as part of our tool, we gave handouts. So we were curious about what people thought about the handouts that we were developing. And there was a little bit of hesitance to be accepting of handouts that they found came from a computer algorithm, right? So if we were telling patients that, our EHR kind of took all the data about you and here's a handout based on what we think we know about you, that was turned some patients off and made them a little more mistrusting. Whereas if that same handout was perceived to come directly from a clinician who knew them, like even if it didn't, if they thought the clinician said, oh, we should print this handout for this patient, that was more welcoming. So, all of the details of these themes are published in Journal of Patient-Centered Research Reviews, and feel free to access that if you're interested in more details of what we found in the quotes. So I'm going to switch gears a little bit and talk about some of our survey work. We haven't published our survey work yet. We're in the process of writing these papers up, but I'll first just talk about our patient survey. So the way we survey patients is that we identify people who had an eligible encounter where the CDS tool should have been used. And then we reached out to those patients within 1 to 2 weeks after that encounter and asked them to fill out a brief survey. So we found we have a sample of 127 patients we surveyed. I think this might just be from our health system, but I'm not sure if it included the other 2 health systems. And we had, they had an average age of about almost 49 years, about half were female. And then we have kind of that varied sample, about a third had an OUD diagnosis, and most of those who did were receiving some sort of treatment. The interesting part about this is even though when we ask patients at the beginning to identify if they've had an encounter recently, only about half of those patients remembered having a conversation about opioids at that visit with their primary care clinician. So either that suggests that patients are not remembering having the discussion, or it didn't come up, or a combination of things could be happening. But when those patients did remember having that conversation, about half said that they brought it up and they initiated that conversation. And about 40% said the clinician did, and then 9% were unsure about who brought it up. We asked our patients, who should be having conversations with you about opioids, and over half said their primary care clinician should be. Again, we kind of saw a mix of other specialists. Some patients were not having their clinician prescribe their opioids or their opioid use disorder treatment. So they, mentioned their prescribing clinician or an addiction specialist or someone in pain management. When that we asked patients who actually remembered having conversations about opioids, how that conversation made them feel. About 37% said that it made them feel cared about. 24% said they were relieved. 15% were just interested in the conversation and with the information they were talking about. And then we had a small proportion, 13% said they felt ashamed by that conversation. And then there was a combination of other feelings that people endorsed, which were both positive and negative. And we asked, open-ended question in the survey about how that conversation made them feel. On the left-hand side, these are generally positive comments, like my clinician cared about me. We're keeping this open dialogue about risk of addiction. They care about that I'm not going to abuse these medicines, and they care about my health. And again, this like caring theme seemed to come through quite a bit. On the other side, there was, some concern. I don't want to be somebody who has an opioid use disorder. And then this also kind of feeling like there's this tension between the clinician and the patient about opioids. Like, I don't want to have to beg for relief. And then, all the way to, anger. I'm furious because this clinician didn't even listen to me. So I think that, the pulls from the systems and the clinicians to limit opioid prescribing and can feel difficult for patients to navigate when they're trying to find relief for managing their pain. And some of that tension came out in our interviews or our surveys. So I mentioned we started off with 127 people that we had completed surveys from, and about a quarter of those only recalled receiving our handout. So it was a much smaller percentage remembered. And, we as a team talk about this and we're like, well, patients are often given a lot of different materials at visits, including like an after visit summary and other things. So it might just get put in the pile and not really be something that they remember. But of those people that did remember, we asked them kind of about their experience and what happened. So about half of them remember getting the handout from their primary care clinician, and whereas about 40% received it from the nurse or medical assistant. So we do find that our workflows, our standard process workflows, tend to vary a little bit from clinic to clinic, where sometimes the nurse prints it and then puts it on the door for the clinician to look at first. Sometimes the nurse or the medical assistant hands it straight to the patient. So it just does vary a little bit from place to place. So some of them received the handout when the PCC was talking to them. Some of them got it at the end of the visit when they were ready to leave and likely didn't have a conversation. And, where about almost 2/3 said that they had enough time to review that handout. About 22% said they actually didn't review that handout with their clinician. And overwhelming majority said they agreed that handout made them feel more comfortable in talking about opioids with their PCC, which is ultimately our goal. We want that handout to kind of initiate that openness or receptiveness from a patient to be open to talking about this with their clinician. And then how did the handout make you feel? Again, cared about. Mostly was that theme that came through. A mix of other things came through, like it's redundant, it didn't bother me. And then, there was a mix of other positive and negative feelings associated with that. Again, people felt lucky to have that handout, and that they're thinking that we care about them or understand that they have some pain, and that we're empathetic to that. Again, there's this redundancy. This is always the same annoying information that I felt labeled by my clinician like a drug addict. So, positive and negative things come out of these conversations. So briefly, where we are with the main trial is we ended enrollment at the end of December 2022 and enrolled over 10,000 patients with high risk for opioid use disorder or who had diagnoses of opioid use disorder. our observation period at the end of December of the last year, so 2023. And so we've been working on finalizing our analyses in partnership with MS. And I know we can't talk about them yet, so but hopefully soon they'll be released. But we have been a very productive team already, even if we haven't published our main results. We've published 7 papers. We have 3 additional papers under review and 7 papers in process. So I think this study is had a lot of interesting findings come from it. And then I'm going to transition in this last part to talk about our supplement, which was a kind of came out of this idea that our clinicians were expressing some hesitancy to talk to patients about with opioid use disorder about treatment. And so we received a supplement, a HEAL supplement to CTN-95 to conduct a trial of a stigma reduction intervention for primary care clinicians. And this paper is published in Addiction Science and Clinical Practice if you're interested in reading all the details, but I'm going to talk about kind of the main design and results. So many of you may be aware that stigma is a barrier to care for people with OUD. There's some research that shows that primary care clinicians carry many of the same stigmatizing beliefs as the general public about people with OUD. For example, that they're responsible for their illness, they're undesirable, angry, dangerous. And we are hearing some of these same things from our clinicians as we're talking about implementing this intervention. And it's made me very nervous that if we don't try to do something to address this, that clinicians aren't going to use the tool and then it's not going to have the benefit that it's supposed to have. And so few interventions have directly tried to reduce stigma among practicing primary care clinicians. There are some that had tried in residents or medical students, but this was a largely untapped area. And when we were reading about what works to reduce stigma, it's generally the best approaches are direct contact with somebody who has an opioid use disorder or the condition that they're stigmatized, and then hearing positive stories or narratives about people with those conditions. Essentially, when you can kind of make that person just be a person that also has a health condition, that can reduce that stigma and the labeling that happens when people kind of put those generalized beliefs on a person. So the purpose of this supplement project was to determine whether we could design a stigma reduction training that reduced stigma among primary care clinicians, increase their intention to get waivered to prescribe buprenorphine, or their likelihood to prescribe it if a waiver were no longer required. So as you can tell, as we were doing this study, the waiver requirements were in the process of changing. And so when we originally wrote the grant, we said we want to make sure more people are willing to prescribe, and essentially that we had to add another question and modify this as we were doing the study because the policies at the national level were changing. And the third thing we were interested in was whether or not it would increase the likelihood that clinicians would actually use the CDS. And our second aim, we wanted to understand whether stigma was related to intentions to get waivered and the use of that CDS as well. So, how big of an issue is stigma for primary care clinicians? So here's our study design. We just did this study at Health Partners, just one of our 3 sites. We had 15 clinics that were randomized to the OUD CDS. And within those clinics, we randomized primary care clinicians to either receive this enhanced stigma intervention training or a attention control training. And the training was really on the tool. So we offered a training for both groups that was kind of more in depth in the tool than what we were doing in the clinics. But the stigma group got kind of this enhanced stigma reduction training, which I'll talk a little bit more in detail about. And then, so this training was a brief online training. Immediately after the training, we did our survey. So we asked them about their stigma towards people with OUD, intentions to get waivered and intentions to prescribe. And then we can monitor use of the CDS for 6 months. Being slow to respond. Okay, there we go. So both groups got this intervention delivered via our online learning platform at our health system. So this is a platform where we do all of our compliance training, where clinicians get a lot of their updates. And so it's a system that our clinicians were very used to using. And we provided both groups evidence-based education about opioid use disorder and medications for opioid use disorders. And we guide them through 4 different patient scenarios, which they could use the opioid use disorder CDS. But our stigma intervention actually got to see videos of patients telling their stories. So this is videos that we created based on real patients. So I worked with Amy Sullivan, who is a local medical historian at Macalester College here in St. Paul. She had been working on a book about opioid use disorder in Minnesota. And so we kind of recreated different stories about different people at different points in their trajectory with opioid use disorder that would be relevant to training for the CDS. And then we hired actors and a videographer to create these videos so that they were really well produced. And I'll share a little bit about what these were. So here are our 4 characters. We really tried to make sure we were varying different demographic characteristics like gender, age, race, ethnicity, and kind of educational background, things like that, so that we were, trying to break some of the intersectional stigma that can happen with having a substance use disorder. And each person was in a different point in their trajectory. And I'm going to share just a clip of Deborah's video because I feel like it was very powerful. She's a fabulous actress in a local
help me understand
area.
a bit better if you can tell me your story.
After graduating high school in 1975, a friend and I took a road trip to Northern California on a lark, and I stayed for 20 years. I met my husband out there. We had 2 children. We divorced when the girls were little, and the next man that I fell in love with was an IV drug user and a dealer, heroin mostly. He encouraged me to try it a few times, and then I couldn't stop. He always had it. My life fell apart. I went from rehab to rehab. I did a little time in jail. I nearly died a few times from an overdose. But the last time I used was 1995, and I never looked back. I even got my girls back in my life. Now, they were teenagers, so their husband, their dad was going crazy at that point. But, I got back on my feet. We moved back to Minnesota. I went to college, got degrees in human services. And now I run my own outpatient treatment program focused on harm reduction and trauma-informed approaches.
Right. And so the whole idea behind these videos is to kind of mimic what you would get with a direct contact of a person with opioid use disorder that some of the other interventions have tried, while sharing these kind of positive narratives of people who have had a fall, had a time when they developed a opioid use disorder, and then they kind of worked through that and then ultimately got better with treatment.
Might help me.
And our measures after we had people do the trainings were the stigma was measured with the difference to sane and blame scale, which is, we used 8 items. So people rate the extent to which they believe these statements, for example, how responsible do you think people with opioid use disorder are for their illness? And higher scores just correspond to greater stigma. And intentions, we use 2 single item measures. So again, I mentioned we had to piece together a combined outcome here with people's intentions to get waivered in the next year or to prescribe buprenorphine if the waiver were no longer required. And that range was 1 to 5 with higher scores corresponding to greater intentions. We also had some interesting secondary measures. We looked at willingness to work with people with opioid use disorder, as well as treatment futility. And so this idea that, even if, treatments are, do they believe treatments are effective? And if they are effective, will people comply or will they use the treatment? Just an interesting question that we had. So here's our consort chart. We ultimately randomized 162 clinicians to one of the 2 interventions, about 80 in each group. And I'm just going to talk about our immediate post-survey results. So we found that 88 people completed one of the interventions. And then because they were randomized before we invited them to participate, I should say. That's why we have this drop off. So people that actually participated, there was about 88 who did that. And then we had them do the survey right after, and that was a high completion of the survey right after that intervention. Just here's some characteristics of the clinicians that did the study. It was about a little over half were female, predominantly non-Hispanic and white, kind of reflects a lot of our clinicians here in Minnesota. But we do have some diversity with clinicians identifying as Asian, Black, or African American. Most clinicians were full-time and very few were waivered. So only 8 clinicians were waivered. And there was a kind of high proportion of people who rarely treated people with OUD. So they reported they treated people 72% a few times a year or less. So spoiler, we found no difference between the 2 interventions in terms of reducing stigma or changing intentions or willingness to work with OUD. So ultimately, we found that this brief online intervention was not associated with a stigma reduction. But we did find that stigma was associated with other things that we measured. So when clinicians reported more stigma towards people with OUD, they also reported lower intentions to get waivered. They reported lower intentions to prescribe buprenorphine. They reported less willingness to work with people with opioid use disorder. They're more likely to say the treatment is less effective and that people would be less likely to comply with treatment. We didn't find that stigma was related to the likelihood of using the CDS tool in the 6 months following the training, but we are measuring this by clicks in the OUD CDS, and our click rate was very low, which you know, a lot of the way our clinicians use it here is probably more through the printout versus like clicking into the tool. So, you know, a summary, we found that the stigma intervention didn't reduce stigma or increase CDS tool use. We think, you know, it might have been too brief. The intervention was designed to take about 20 to 30 minutes, something that clinicians could do in between their sessions, you know, so clinician time is valuable and, you know, adding a lot of extra content is probably not a feasible way to deliver. The online delivery could have also made a difference. They might not have paid a lot of attention to the training. We had no way to kind of monitor engagement as people were playing the videos or doing that. We do think stigma likely plays a role in access to care for patients with OUD, and clinician stigma is a big issue that we have to figure out what to do about it. So we do need to figure out or design effective interventions to combat stigma among healthcare providers. But this is very challenging work, as much I mentioned, stigmatizing beliefs are hard to change. It takes sometimes potentially repeated exposure or kind of more intensive interventions. And with clinicians who are in practice, again, their time is very limited and it's difficult to reach them. So our strengths of this supplement were the randomized design. Our PCCs were blinded to their intervention assignment, so they were unaware that they were getting one of 2 versions, or they were aware they're getting one of 2 versions, but they didn't know what the differences between them were. We were targeting practicing clinicians. So these were, you know, people that are out in practice, seeing patients with opioid use disorder. And we were, you know, very proud of our narratives that we had with our medical anthropologist and their videos. We felt like they were very strong components. However, we couldn't measure engagement in training or treatment fidelity, and we used a self-reported measure of stigma, which might be subject to bias reporting if people are not willing to report their true beliefs. So it's clear that we need to find effective approaches to reduce stigma towards opioid use disorder among healthcare professionals, and interventions should include more educational and skills-based components. You know, we were pretty covert in our way of trying to address stigma. We were, you know, using the narratives and not really saying we want to reduce your stigma towards people with OUD. But, you know, I think you could we could use more things that would help identify language changes that people could use to reduce, stigmatizing language. Also, having clinicians reflect on their own biases and potentially challenging them a little bit more. And that kind of brings that covert more overt and really starts to get them thinking differently. And then again, repeated intervention exposure over time may be more helpful. So I will stop there and say thank you. And I think we can open it up for questions.
Thank you so much. That was wonderful information. We don't have any questions at this time, but I'm wondering, we have a few minutes. Would you like to go back and play the other actors' videos for us?
Oh, I didn't put them all in there.
Oh, okay.
I only put one because I thought, oh, there's no time to put them all in there. But yeah, I have them. If people are interested and want to see them, or feel free to reach out to me. I'm happy to share the content.
Perfect. Meg, is there anything else you'd like to mention?
Maybe give people just a second to see if anyone has any questions they want to put in chat. Sometimes it takes a minute for folks to catch up. If not, I can also just mention our next webinar, which will be in July, which is July 17th, and it'll be about ASAM criteria implementation and science-based implementation strategies. See if anyone has any questions. Here we go. Questions are coming in.
Perfect. Okay, our first question is, why was the stigma intervention delivered online instead of in person?
Great question. So I think there's a few reasons we did that. One is just feasibility. Clinicians are in the study are across 15 clinics, and so reaching them in person all at the same time, or even different times, would be challenging. But also, this happened during the pandemic, so we delivered this intervention, and I think it was April of 2021. So, it was a time where nobody was doing anything in person. So that was the other reason it wasn't in person.
I don't know if you mind if I ask you a question, but I have a question for you. Okay, so I don't know if you know this, but I'm the CTN dissemination librarian. And I was wondering if the patient handout is available, if that's something that could be added to the library. It would be a great resource to make available if it isn't available, or if that's something that you need to hold back because you're still doing work on that.
You're talking about the patient handouts for starting Suboxone?
Yeah.
Oh, sure. We're happy to share those.
Oh, that'd be great. I would love to get a copy of that. It
Okay.
sounds like a really interesting resource, and maybe something that would be of use to just the general public to have that information. Cool.
And Meg, I think this is a question for you. Will they be able to share this recording with the providers in clinics?
Yeah, so this recording is going to go up on the Northwest ATTC website. It should be up actually later today. And I'll be sending a link out in an email after this session. Give me like half an hour after we sign off, and that'll come to you. And you can share this recording with anyone you want. It'll be available to the public, so you can share with anyone you want, for sure. And also, just so people know, the CTN Dissemination Library, which is ctnlibrary.org, has a lot of information about this study. And also, it has 4 of the 7 published articles. I didn't realize there were 7. I'm missing 3. So I'll reach out to you and find out which 3 I did not find out about and add those. So you can find the articles that have come out about this study. You can find information about both the original study and the stigma study follow-up. And you can get all of the published articles. And if you don't have access to the journals, you can request them from the library, and we can send you the PDFs for those for free. So
Nice.
Okay, we have another question. Give me a minute because this is a long one here. Speaking of getting more clinicians on board with treating OUD, what do you think about the term medication for opioid use disorder? Given that we don't use those types of terms for other disorders or diseases, e.g. medications for hypertension, we just call them by name. Perhaps it further stigmatizes OUD.
It's an interesting question. You've got a really good point, Jordan. I don't know. We certainly could. I think it's still helpful to have some sort of umbrella term to sort of otherwise it gets clunky, right? When we're talking about Suboxone, IM naltrexone, methadone, like, can we still have some sort of term like antihypertensives? I don't know. When we started, the term we used before suggested that treating OUD with medications was optional. And so this was meant to be sort of an advance towards this is the standard of treatment. But I still think you've got a point. Be nice if we could come up with sort of a more global term that it maybe doesn't lend itself to further stigmatizing the disease. I don't know. Stephanie, any thoughts?
Yeah, no, I think it is an interesting thought. I was thinking, the former term was medication assisted treatment, which was like very vague, and it wasn't, medication assisted treatment for what? And so I agree, it kind of made this idea that medication was optional. But I think, as we've learned more about treating opioid use disorder, we're talking about the kind of gold standard now for treatment is a medication. It's the most effective treatment. So I think coming up with an umbrella term that would capture the different medications that are available that doesn't use the term opioid use disorder. I don't even know what that would be, but it would be interesting to think about.
I love a different acronym. As a psychiatrist, it gets confusing talking about moods.
Yes.
Yeah. I don't know. Jordan, you have any thoughts about what we could call those? Maybe just by name you said, but I don't know. We like to shorthand things.
Yeah. I mean, I've always say buprenorphine, and I don't say buprenorphine and naloxone. I try not to say Suboxone, stay away from brand names. And, but there are different things out there too.
Yeah.
Okay, thank you. We'll just give it one more minute to see if any more questions come through. Here we go. Will the study obtain information about uptake of the CDs tool? That is longer term use. The system seemed complicated to use.
Yeah, I think Stephanie alluded to this a bit. There's really two parts to the intervention. The first one is it may seem weird to reduce a pretty technical intervention to a couple pieces of paper, but clinicians like it because they can review it with patients and write on it and send it home. And patients seem to like having something tangible as well to kind of refer to. So that seems to be, for all of these wizard interventions, sort of the main component of it. With opioid use disorder, I think the big difference between that and, let's say, cardiovascular risk is clinicians aren't as familiar with it. And so we thought it could be helpful to have this kind of modular component to it. So for clinicians who wanted to prescribe Suboxone, we could kind of give them that additional support. Having said that, Stephanie already said, we don't have a lot of clinicians clicking in to use that functionality. Whether it seems daunting or whether, to be perfectly honest, we know any additional clicks in Epic, it makes it much less likely that clinicians are going to use it. And so that's one reason we've always positioned these interventions to be triggered by rooming staff actions. Rooming staff are really great about incorporating this into their workflow. They see it, they click it, they print it, they distribute it, and we measure that. It may be too much. There's sort of, we sort of found this out with a pilot. Those clinicians who are really comfortable with prescribing buprenorphine already have their established workflows. And those who aren't are giving us lots of feedback that they're not necessarily going to start. And so there just may not be this audience in between to use that full functionality of the tool. Having said that, we've also toyed around with the idea of making this sort of a standalone online tool that would be available to clinicians. The downside for that is everything we showed you that is pre-populated in the tool, clinicians would have to input or at least have some idea of, things like prior med trials, relative contraindications, those sorts of things. But we have had clinicians ask us to make it a standalone tool so they could access it on their own. So, and Jordan says, not yet. Thinking about mood might make things sound too special and then not appropriate for primary care and other medical setting. Yeah, you could be right. It could seem less accessible to primary care clinicians. They have to know a lot about a lot. And I think we heard from our clinicians, I don't think we stated this overtly, but they don't, at least up until this newest crop of clinicians, they really don't get much training on substance use disorders or the use of Suboxone. Yeah, and Elizabeth, I agree. Suboxone's about the safest opioid out there, and yet I won't get too political, but I don't think we did ourselves any favors with these policies that restricted use of buprenorphine early on, and then said, you know what, everybody can prescribe it if you go through this training. The impression was already out there that this was a more complicated medication, and yet, prescribers, we've certainly seen are prescribing opioids at lower rates than they used to, but they're still prescribing quite a bit.
Hey, do we have any other questions? Okay, well, we would like to thank, excellent presentation, everybody says. We would like to thank you for your presentation. It was absolutely wonderful. And thank you, everybody, for coming and listening. And we hope that you have a great day.
Thanks, everyone.
Thank you.